Hi, and welcome to our webinar today. My name is Kate Moore, and today I'm going to be talking with you about the newly released JNC-8 hypertension guidelines. There were two other hypertension guidelines released by other organizations in 2013, but today we're only going to be focusing on JNC-8. At the end of today's presentation, you should be able to review the historical goals and treatment of patients with hypertension, determine the optimal threshold for initiating treatment in patients with hypertension, establish evidence-based treatment goals for patients with hypertension, and also select the optimal treatment for patients with hypertension, focusing on key evidence regarding diuretics, combination therapy, and beta blockers. I have no financial disclosures related to today's presentation. So cardiovascular disease is the leading cause of death in the United States. It's responsible for about 17% of our national healthcare expenditures. And it's estimated there's about 2 million heart attacks that occur annually in the United States. With our growing and expanding and aging population, it's estimated by the year 2030 that 40% of the United States will have cardiovascular disease. And this will account for about $1 trillion a year in our healthcare expenditures. So as you can see, very significant a problem in our country. Many of you are familiar with the risk factors for cardiovascular disease, and this is by no means a new list. Each of these risk factors is independently important. Risk factors such as cigarette smoking, elevated cholesterol, age, diabetes, obesity, physical inactivity, and excessive alcohol use all should be addressed if they can be modified in every individual patient. Today, remember, we're going to be specifically focusing on the risk factor of hypertension. So I personally love prevalence maps, and this is a map from the CDC that's addressing the prevalence of hypertension in our country. Now, this is self-reported prevalence. Patients were asked if they had ever been told by a doctor, nurse, or other health professional that they have high blood pressure. So you can see, not surprisingly, the darker red shows that the prevalence is highest in the southern states, which we expect with that being the stroke belt. You can also see, though, that there is a prevalence in other states all across the country, so it's by no means just a southern problem. It's a problem all across our country. This is also probably an underestimate of prevalence of hypertension in the United States because it was self-reported. So we've talked about hypertension being a risk factor for heart disease and cardiovascular disease. It's also a risk factor for stroke. The risk goes up with a blood pressure greater than 140/90, and literature has shown that diastolic blood pressure is more predictive of that risk in younger patients or those less than 50 years old, and systolic blood pressure is more important in those over 50 years old. We've seen in epidemiologic data that there's a twofold increase in the risk of cardiovascular disease when the blood pressure goes up into the 130s compared to a quote-unquote normal blood pressure of less than 120/80. In the year 2008, hypertension was a primary or contributing cause of death for almost 350,000 Americans. So again, very significant and something that we need to be addressing. So before we talk about what's new, let's review where we were with hypertension before these guidelines. So JNC-7 was our most recently released guideline that addressed different blood pressure goals in patients who had high blood pressure. We also had the American Heart Association that released blood pressure goals for different comorbidities. And you can see in this chart here, there is some discrepancy across guidelines. Primarily, JNC-7 didn't address some of the comorbidities that the American Heart Association did. There's also been a lot of data that's come out since either of these guidelines were released back in the earlier 2000s. That's led us to wonder if this is really the best. We do know that lower blood pressure is not always better, as we have seen some studies that have shown higher mortality with lower diastolic blood pressure, and we'll talk about some of those. So based on the comorbidities of a patient, JNC-7 gave us recommendations on what specific antihypertensive we should be using. So there's a lot of overlap in these different categories, and some really argued that this didn't help you make a decision very well because you had so many choices for every different compelling indication. We'll talk about some of these compelling indications when we get into what drug to choose with JNC-8 guidelines. So lastly, in our review, let's review what our treatment algorithm was. So if a patient was not at their goal blood pressure, meaning their blood pressure was over 140/90 or over 130/80, we had some different choices for how to select drug therapy. If they had no compelling indications, meaning no comorbidities other than hypertension, and their blood pressure was between 140 and 159 systolic or 90 and 99 diastolic, the guideline said pick a thiazide-type diuretic for most. You might consider some other therapies as well. If their blood pressure was higher, meaning greater than 160/100, the guideline suggested 2 drug combinations. And again, if patients had any compelling indication and their blood pressure was not at goal, we used drug therapies based on their compelling indication, as you saw on the previous slide. So now we finally have JNC-8 after much anticipation and waiting. JNC-8 took a very long time to come out because it was a much more detailed and evidence-based guideline that was produced. The authors of JNC-8 did a systematic review going all the way back to 1966, pulled literature all the way through 2009, and they focused on 3 key critical questions. Those critical questions were, does initiating antihypertensive therapy at specific blood pressure threshold improve outcomes? So basically, when should you initiate treatment? Does the treatment with antihypertensive therapy to a specified blood pressure goal lead to improvements in outcomes? In other words, how low should you go? And then, do various antihypertensive drugs or classes differ in comparative benefits and harms on outcomes? So once we have our goal, how do we get there? So we're going to review the recommendations for these 3 key questions today. It's important to remember that these recommendations are going to be based on the evidence that was pulled in the trials that were included in this systematic review. It has been some fodder for some editorials that have come out since JNC-8 was released, but they pulled trials that specifically addressed these critical questions. So some trials were not included that some might argue should have been. To help us go through these recommendations, we're going to use a patient case. So I want to introduce you to our patient, Harry Nabb. This patient is a 49-year-old Caucasian male. He has no significant past medical history. He presents today for his routine yearly physical. His vitals are blood pressure 166/88 the first time it was taken, 134/84 the second time it was taken. He is 5'10" and he weighs 198 pounds. So we'll come back to some of this information as we go forward. Well, let's start with our first key question, which is, when should we initiate treatment in a patient who is hypertensive? So one study that sheds light on this question is the TROPHY study. The study was published in 2006, and it looked at patients with pre-hypertension, which at that time was defined as patients with a systolic blood pressure between 130 and 139, or a diastolic blood pressure less than 89. And these patients were randomly assigned to receive 2 years of either candesartan treatment or placebo. And they looked to see if this treatment would prevent or postpone the development of hypertension. And they defined the development of hypertension, you can see in their endpoint, as a systolic blood pressure over 140 or a diastolic blood pressure over 90. So you can see with this chart, more people, obviously, in the placebo group developed hypertension at both 2 and 4 years compared to patients in the candesartan group. That's not surprising. This number was statistically significant. You can see with the p-value favoring treatment with candesartan. Adverse effects were similar between the 2 groups. So the authors concluded that treating pre-hypertension can decrease the development of hypertension. The important thing to remember, though, is they didn't do any sort of cost effectiveness analysis in this study. So we know that treating patients early might be very costly if we're not getting that much benefit out of it. They also did not look at true health outcomes. They looked at development of hypertension, but not mortality, hospitalizations, number of strokes, heart attacks, anything that we say really matters in terms of cost effectiveness. We also had a Cochrane review that was published in 2012 looking at treatment of mild hypertension. So this meta-analysis looked at trials who had patients included that had no history of cardiovascular events, and their blood pressure was between 140 and 159. So these are patients that we would diagnose with hypertension. And they looked at the effect of treatment versus no treatment on the number of cardiovascular events, stroke, and mortality. They also looked at withdrawals due to adverse effects. And you can see the 4 trials that were included in that study. It only included 4 trials because there was only 4 trials that really fit that criteria or that had subgroup analyses looking at patients who had no history of cardiovascular disease and blood pressures in that range at baseline. So you can see in this chart for the outcomes related to cardiovascular disease, stroke, and mortality, there really was no difference between patients who were treated and those who were not treated. You can tell that by the relative risk and the confidence interval crossing 1 for all of those. Withdrawals due to adverse events was significantly greater in those patients who were treated versus those who were not treated, which is not surprising. But we did see that there were more withdrawals due to adverse events from that treatment. So in conclusion, for this Cochrane review or a meta-analysis, you can see that the treatment of mild hypertension for 5 years did not significantly reduce the mortality, stroke, coronary heart disease, or cardiovascular events. So we didn't really find that it was that beneficial. Some things to think about, though, when we interpret these results is that the therapies included in those studies don't match the drugs that we currently use. So it might be that those therapies just were not effective. Also, we've got other literature that shows outcomes are beneficial on a smaller scale than a meta-analysis when you look at a smaller population with similar baseline blood pressures. And we'll talk about some of these trials later. It might also be that the negative impact of hypertension takes longer than 5 years to develop. So those patients might not have had an event in those 5 years, but they could have had an event later on. And remember that these results do not apply to patients who have a history of cardiovascular disease. It's only those who have no history of cardiovascular disease. So what does JNC-8 say about this key question? When should we initiate treatment? Well, they break it down into 2 different age groups. So they say that patients over the age of 60, they should start treatment when their blood pressure is either over 150 systolic or over 90 diastolic. For those patients less than 60 years of age, we should begin therapy when their blood pressure is over 140 systolic or over 90 diastolic. For the sake of time, I didn't go into the differences in these 2 age group cutoffs, but just suffice it to say, in summary, it's that the older the patient, the more likely there could be harm from using multiple agents to get to a lower blood pressure. And we don't have the evidence to show that there is a true benefit there. These are strong recommendations from JNC-8 in terms of their evidence level that show using these numbers will reduce the risk of stroke, heart failure, and coronary heart disease. I do encourage you to pull these guidelines and read both the guideline document and their supplementary materials if you're interested in learning more about the discrepancies between age. So on to key question number 2. What is our optimal blood pressure goal? This is where there's been a lot of new literature come out and where a lot of people were wondering if JNC-7 actually had it right or if we were being potentially too aggressive. So let's revisit our patient. A year has passed and he now returns for his repeat physical. He did not make any of the lifestyle changes that were recommended to him, and he's currently not taking any medications. And you can see his blood pressure is there, was 144/88, 142/84. You can see, obviously, his height hasn't changed. He's gained a little bit of weight. His weight is now 215 pounds, which gives him a BMI of 30. Based on his labs, you can see he's got some elevated cholesterol levels. He also has diabetes according to that A1C of 7.8. So we need to keep that in mind as we start to think about what his goal will be. So remember this as we go through talking about some of these trials, and we'll come back to our patient and ask a question. So one trial that looked at goal blood pressures was the Hypertension Optimal Treatment, or the HOT trial. And this trial compared 3 different diastolic blood pressure goals. was less than 90, less than 85, or less than 80. All patients included in this trial had a diastolic blood pressure over 100 at baseline. So they had a 3-step treatment approach. They started with every patient on felodipine. If they needed additional therapy to get to their goal based on what group they were randomized to, they either got an ACE inhibitor or a beta blocker. And then once they were on 2 drug therapy, their doses were titrated until they reached their goal. And the endpoint the authors looked at was the incidence of major cardiovascular events. That included fatal or non-fatal MI, stroke, and cardiovascular death. So I always like to look at baseline characteristics whenever I'm analyzing a trial to see who was actually included in the trial. It kind of helps to go further than the inclusion criteria because you can see what patients actually are being analyzed. So you can see most of these patients were in their lower 60s, about a 50-50 split between males and females. You can see their blood pressures at baseline was 170 over 101/05 for their baseline blood pressure, which is significantly elevated based on our previous recommendation, all patients that we would begin treatment for. Most of them had been treated for high blood pressure at some point in their history. One thing I do want to point out is their comorbidities. Really, these patients are very low risk. Very few of them had had a cardiovascular event or stroke, and only 8% in each group had had diabetes. That comes out to be, based on the number of patients included, about 1,500 patients total out of 18,000 that had diabetes. That'll come back to be important in just a minute. So for the results of the HOT trial, you can see the different blood pressures that were achieved. Obviously, systolic blood pressure decreased in the more intensive diastolic blood pressure groups, which we would expect. You can see the less than 90 group actually got to their goal. They got to a diastolic blood pressure about 85. The less than 85 group got to about 83. The less than 80 diastolic blood pressure group didn't quite make their goal. On average, their blood pressure was 81 for their diastolic. You can see, looking at the different events, really no difference in the total trial population in terms of major cardiovascular events, the number of myocardial infarctions, strokes, or mortality. No difference between those 3 diastolic blood pressure groups. So we can't say that a lower diastolic blood pressure is better than a higher diastolic blood pressure in terms of cardiovascular events. One thing I do think is interesting is looking at those mortality numbers. You can see that as we got tighter in terms of our control of diastolic blood pressure, the incidence of mortality actually increased. Now, it wasn't statistically significant, but there was an increase numerically in the number of deaths for patients in the less than 80 group compared to those less 90 or less than 85. So looking at the subgroup analysis for those patients who had diabetes, since we're talking about our patient who does have diabetes, you can see that there was a statistically significant difference in major cardiovascular events and cardiovascular mortality in the tighter control groups. So the less than 80, although they didn't quite get to less than 80 was better than less than 90 in terms of cardiovascular events and cardiovascular mortality. It's important to remember here, though, that this was a very small number of patients compared to the overall trial population. Remember, only about 1,500 patients out of 18,000. So not something we could really completely hang our hat on, but this was one of the trials that JNC-7 and other guidelines have hung their hat on for quite some time, recommending a less than 80 diastolic blood pressure goal for patients with diabetes. Another study that was recently released that compared goal blood pressures was the ACCORD blood pressure study. Some of you might be familiar with the ACCORD trial for its diabetes endpoints, but they also had a blood pressure arm. So they compared intensive therapy, which they defined as a systolic blood pressure less than 120, versus standard therapy, which was a systolic blood pressure less than 40. All the patients included had type 2 diabetes. Their A1C had to be over 7.5. They also had to be over 40 years old with cardiovascular disease or over 55 years old with risk factors for developing cardiovascular disease. The endpoint that the authors looked at was the first occurrence of major cardiovascular events. That included non-fatal MI, non-fatal stroke, and cardiovascular death. You see with our baseline patient characteristics, Again, similar to our hot trial, low 60s for the age, 50-50 male-female. About 30% of the patients had a history of cardiovascular disease, so we're getting into the more moderately higher risk patients. You can see their systolic blood pressure was 139 at baseline. So most of our patients included in this trial are going to already be below the goal of the standard therapy group. For the results, I want to point out that the systolic blood pressure achieved in each group, for the intensive group, they got blood pressures down to 119. For the control group, their blood pressure got down to 133 systolic. So we're basically comparing 119 to 133. And you can see that there was not a statistically significant difference between these two groups. So an intensive systolic blood pressure performed the same as the standard or control blood pressure of 133 in terms of cardiovascular endpoints. Here's the numerical data, a little bit different than the chart you saw in the previous slide. You can see again, primary outcome, no statistically significant difference there. Breaking it down to the components of that primary outcome, no difference in non-fatal MI. There was a statistical difference in the incidence of stroke though. So we can see that intensive therapy is better than standard therapy. So that lower blood pressure goal was better than the higher blood pressure goal in terms of preventing stroke. Again, no difference in all-cause mortality, no difference in death from cardiovascular causes. In terms of adverse events, this is something we'd always want to think about if we are pushing someone to a more intensive therapy, because we're probably going to have to use more drug therapy, which is going to lead to more adverse events. So not surprisingly, there were more adverse events in the intensive therapy group versus the standard therapy group. Would not surprise us. Most of that was hypotension, did have some others, hyperkalemia, bradycardia or arrhythmias. Hyperkalemia is probably prevalent because a lot of these patients were more than likely using an ACE inhibitor or an angiotensin receptor blocker, which can cause hyperkalemia. I really like this chart. It comes from an older review looking at the cardiovascular outcomes between groups in various hypertension trials that included patients with diabetes. The top number you see in each bar is the control group, and the bottom number is the treatment group of the trial, whether it was treatment to a goal blood pressure or treatment with a certain drug therapy. You can see the difference between the two groups in the white area, and you can also see the blood pressures that they achieved indicated by the top and bottom numbers in each bar. The dotted line going horizontally is the 130 systolic goal that we have had for patients with diabetes for many years. You can see in the bars that are light gray, that means there was a difference found in the trial, a statistical difference found in the trial between the two groups. In the bars with the stripes, there was a difference in subgroups only, and in the solid gray bars, there was no difference found. So basically, what this chart is showing us is that in the majority of our blood pressure trials in patients who had diabetes, we see that there is a statistical significant difference found between the treatments, regardless of the goal blood pressure achieved by the treatment group. So most of our treatment groups did not achieve a blood pressure less than 30, and we still saw a significant difference in the outcomes that were being investigated. Of note, though, the ACCORD study was not published at the time, so it's not included in this review. So basically, this is showing that we don't have evidence to support that lower 130 systolic blood pressure goal. So what does JNC-8 say about our optimal blood pressure goal? Well, again, they're going to break it down into different groups. So our older patients, those over 60 years old, their goal should be less than 150 over 90. Easy to remember because that's when we're going to initiate treatment. And they do recommend it's optional to attempt to get a blood pressure less than 140 systolic if the treatment the patient's on is well tolerated. For our younger patients, those less than 60 years of age, the goal blood pressure would be less than 140 over 90. Patients over 18 who have diabetes, goal blood pressure less than 140 over 90. And also those over 18 with chronic kidney disease, goal blood pressure less than 140 over 90. So basically, we have a more standard approach to blood pressure goals for all patients. These guidelines do place a lot of emphasis on the ease of implementation for the best level of evidence. So they make several notations in their manuscript about if there is a similar blood pressure goal for different groups of patients, it's more likely that clinicians will be able to achieve that goal, remember and achieve that goal. Moving on to our last key question, we'll now talk about, is one agent or combination of agents better than another? It's a very complicated question and one really that we could spend an hour on by itself. We'll hit the highlights of some things in the JNC-8 recommendations. So just to review, we have a lot of antihypertensive therapies out on the market today. Today we're going to be talking about mainly thiazide and thiazide-type diuretics, angiotensin converting enzyme inhibitors or ACE inhibitors, angiotensin receptor blockers or ARBs, and also beta blockers. This does not mean that the other agents do not have a role in therapy, just purely that we had to pare it down to the major recommendations and the major changes in these guidelines for time's sake. So starting with thiazide-type diuretics, JNC-8 says that there is a similar benefit on overall mortality and coronary heart disease outcomes with thiazide-type diuretics compared to ACE inhibitors, calcium channel blockers, beta blockers, or alpha-1 blockers. So there's a lot of literature that we could talk about for where they pull that recommendation from. But specifically, some of the two key thiazide diuretic trials were the ALLHAT trial and the ANB-P trial. And these trials compared thiazide diuretics to ACE inhibitors primarily. ALLHAT also had a calcium channel blocker arm. And the ALLHAT trial found a reduction in the 6-year rate of stroke, but they found no difference in combined fatal or non-fatal MI. They also found no difference in overall mortality between ACE inhibitors or the calcium channel blockers. Interestingly, they found a greater reduction in stroke in the Black population compared to an ACE inhibitor, suggesting that the thiazides were better for that population. The ANB-P trial overall found no difference in coronary events with the thiazide-type diuretics versus the ACE inhibitor. One key difference that we need to point out between these two trials, though, is that the ALLHAT trial used Chlorthalidone and the ANB-P trial used HCTZ. We might think, no big deal, very similar drugs. However, there is actually a big difference between these two therapies. So we won't go into great detail on that difference, but I do want to highlight a clinical trial overview comparing Chlorthalidone to HCTZ. This is a summary chart comparing the evidence between these two drugs. You can see the boxes that are highlighted yellow or orange are the ones where there was a statistical significant difference found between Chlorthalidone or HCTZ and its comparator. So you can see that the difference found is much more common in the Chlorthalidone group versus the HCTZ group. The takeaway from this slide is that evidence suggesting benefit with thiazide-type diuretics really comes from Chlorthalidone and not from HCTZ. There's been a lot of postulated thoughts on why that difference might exist. Nobody has truly been able to explain. However, one thing that I do think is interesting is this trial that looked at the change in blood pressure every hour between Chlorthalidone and HCTZ. You can see Chlorthalidone in the light gray dots and HCTZ in the solid black dots. Early in the morning, you can see that Chlorthalidone has a greater decrease in blood pressure than HCTZ, suggesting maybe it has a longer duration of action than HCTZ. There is often reported a high incidence of myocardial infarctions or cardiovascular events that occur in the early morning hours, which might be why Chlorthalidone is slightly more protective. And you can see that that difference really persists throughout the day. There's a greater change in blood pressure with Chlorthalidone than HCTZ for almost 24 hours. So a few important things to note regarding thiazide-type diuretics is that Chlorthalidone does have a longer half-life, and you saw potentially a longer duration of action. It's also about 2 times more potent than HCTZ. We do know that doses over 25 milligrams of Chlorthalidone and HCTZ don't offer any more benefit than the 25 milligram dose, so don't exceed 25 milligrams. There's no difference in the incidence of hypokalemia. It is a dose-related side effect, so again, a reason to limit your dose to 25 milligrams. And neither of these drugs is going to be beneficial in a patient with renal dysfunction because they can't get to their site of action. I'm not saying that overall every patient on HCTZ should be switched to chlorthalidone. Just wanted to point out that our evidence with thiazide-type diuretics largely points to chlorthalidone being the agent with the most benefit in terms of cardiovascular outcomes. So moving on to beta blockers, there's been a lot of chatter since JNC-7 was released about beta blockers. And one of those was in 2004, a meta-analysis was published showing really no difference and potentially some harm with atenolol compared to other drugs. So comparing atenolol to placebo, there was a decrease in blood pressure, obviously, but no difference in all-cause or cardiovascular mortality, no difference in reduction in stroke. Then when we compared atenolol to other antihypertensives, there was no difference in blood pressure lowering and also a higher mortality rate with atenolol. So that was concerning and started to raise some eyebrows to say, maybe we need to take a second look at our beta blockers. So in 2012, the Cochrane review group put out a systematic review looking at beta blockers and hypertension. This was 13 trials total, and they compared beta blockers to placebo, diuretics, calcium channel blockers, and drugs in the Renin-Angiotensin aldosterone system. And you can see the number of studies and the number of patients included with each of those comparisons, and then the risk ratio and confidence interval for the outcome they looked at. So in terms of total mortality, atenolol, which was the primary beta blocker used in the majority of these studies, beta blockers showed higher mortality rates compared to calcium channel blockers, no difference really in the other agents. It showed a higher risk of stroke compared to calcium channel blockers and Renin-Angiotensin aldosterone agents. No difference in terms of coronary heart disease, so we think we're okay there. And there was obviously a much higher withdrawal due to adverse events compared to all other therapies. Again, the majority of these trials used atenolol as the beta blocker of choice. So I'm not suggesting that beta blockers are bad and we should never use them. What I'm suggesting is that there's probably a limited role for first-line therapy unless there's a compelling indication. And 2 times that we know beta blockers are absolutely beneficial is in patients with heart failure combined with an ACE inhibitor, and also those patients who have had a recent MI. The duration of the use of a beta blocker after MI has recently been questioned, but currently literature is showing benefit probably lasts for 2 to 3 years and continue longer if the patient's not having any adverse effects. Beta blockers are less tolerated than other agents, as many of you are probably aware. They have more fatigue and exercise intolerance. Bradycardia is a significant side effect. Sexual dysfunction can be significantly concerning, especially in our male population, and bronchospasm can happen with higher doses. All beta blockers are also not created equal. The majority of our negative data, again, is with atenolol. We don't know that that necessarily can be extrapolated to all beta blockers. There's different selectivities for the beta-1 receptors versus the beta-2 receptors. The route of elimination is different. Atenolol is primarily excreted renally. And the FDA-approved indications are different, and the indications for which the different beta blockers have evidence for varies. We know we need to monitor the heart rate very carefully in patients on beta blockers, and we have to be very careful if we're initiating or titrating a beta blocker in a patient with heart failure. Remember, any selectivity that a beta blocker might have, specifically selective for the beta-2 receptors in the heart, that selectivity can be lost at higher doses. And we do have to taper beta blockers. The risk of rebound hypertension, angina, and sudden cardiac death does go up if you suddenly stop a beta blocker. So the recommendation is to slowly taper off the beta blocker if you're going to discontinue it over 1 to 2 weeks at least. In terms of ACE inhibitors and angiotensin receptor blockers, I don't want to spend a lot of time on this, but they have always been mainstays in our hypertension treatment since they have arrived on the market. So I'm going to talk about a few key changes that JNC-8 did make. They say that ACE inhibitors reduce the incidence of heart failure but they have a similar effect on other cardiovascular, cerebrovascular, and kidney outcomes and mortality compared to calcium channel blockers. They do note that the ACE inhibitors led to a higher incidence of stroke in the general Black population compared to calcium channel blockers, and that comes from the ALL-HAT trial that I mentioned earlier. ACE inhibitors do improve kidney outcomes compared to calcium channel blockers or beta blockers. However, they don't improve cardiovascular outcomes. Again, this comes from the systematic review and meta-analysis they did on the trials that were included. For angiotensin receptor blockers, JNC-8 says there's no trials of sufficient quality to determine whether initial therapy with ARBs improve the outcomes compared to other therapies in the general population. So basically say they don't have enough evidence to really make a recommendation on using an ARB versus another drug. ARBs do improve kidney outcomes in those with proteinuria and hypertension compared to a calcium channel blocker, but again, no evidence on cardiovascular outcomes. So just some pearls with those renin-angiotensin aldosterone agents. Combination therapy is not recommended to be used. There is an increased risk of hyperkalemia. There's no difference in clinical outcomes if you use the combination of the two. So you're really just increasing the patient's risk. Avoiding the use of ACE inhibitors or angiotensin receptor blockers in combination with our direct renin inhibitor or aliskiren in patients with diabetes and renal insufficiency is a very strong recommendation that came from a trial that was released. It's not specifically addressed in the JNC-8 guidelines, but I do want to remind you of that. Should not combine a direct renin inhibitor with either an ACE or an ARB in those patients. The risk of angioedema is going to be greatest with our ACE inhibitors compared to the ARBs or the direct renin inhibitors, but it can happen with all three classes, so that's important to remember. We have to monitor kidney function with these agents, and if there's an increase, we do want to discontinue if that increase is greater than 30%, and these drugs should not be used in our pregnant patients or in those that are at their childbearing years. So to summarize what JNC-8 says about what initial agent should be started in our patient populations, the general non-Black population, including those with diabetes, should use either a Thiazide-type diuretic, calcium channel blocker, an ACE, or an ARB. So that's a little bit different from our previous compelling indications. The general Black population, including those with diabetes, should use a Thiazide-type diuretic or a calcium channel blocker. Patients with chronic kidney disease should be started with an ACE or an ARB first. The guidelines put emphasis on starting therapy and reaching and maintaining a goal blood pressure more so than they do on the specific agent. So last but not least, I do want to touch briefly on combination therapy. We know that a lot of patients who have hypertension are going to need more than one drug in order to reach that goal. So the ACCOMPLISH trial was one trial that looked at combination therapy in our high-risk patients. So they had a blood pressure over 160, either on or off therapy. And they also had to be over the age of 60 with one risk factor, or between the ages of 55 to 59 with two risk factors. And you can see the titration and the drugs used in this trial. They compared an ACE inhibitor, an HCTZ combination, to an ACE inhibitor and amlodipine combination, and stepped up the doses appropriately. The primary endpoint the authors looked at was cardiovascular event or death from cardiovascular cause. So the results of the ACCOMPLISH trial showed a significant benefit in the ACE inhibitor plus calcium channel blocker group compared to the ACE inhibitor and HCTZ group. Now, could this be because they chose to use HCTZ and not chlorthalidone? Obviously, we don't know what would have happened if they used chlorthalidone instead, but it did show in this high-risk patient population that there is a statistically significant benefit to using ACE inhibitor and calcium channel blocker first as your combination therapy. No discussion of hypertension would be complete unless we touched on lifestyle modifications. These lifestyle modifications have not changed, and we need to stress them in all of our patients who have high blood pressure. DASH diet is what the JNC-7 guidelines originally came out with, and that's a diet focusing on fresh fruit, fresh vegetables, low fat, whole grains, low in saturated fat, low red meats, and obviously reduction in our sugar intake. Implementing a DASH diet can result in an 8 to 14 millimeter per mercury decrease in a patient's blood pressure. Limiting alcohol can obviously reduce blood pressure. Exercise, doing cardiovascular exercise 30 minutes most days of the week, can show a reduction. And weight reduction is also very, very important. Implementing this diet would result in weight loss for most patients, and that can lead to anywhere from 5 to 20 millimeters of mercury reduction in blood pressure. So it can be very significant. We do need to remember to emphasize these changes in all of our patients. So just to give you the algorithm that came with the JNC-8 guidelines, we start with lifestyle modifications, and then we're going to set our goal blood pressure based on either the age and the comorbidities of the patient. So remember, those over 60, their goal is less than 150 over 90. Those less than 60 with comorbidities, their blood pressure goal is going to be less than 140 over 90. Then we're going to choose our therapy, either based on one of those comorbidities. If it's chronic kidney disease, we're going straight with an ACE or an ARB. If they don't have chronic kidney disease, we have to look at their race. If they're Black, we have two choices, either a Thiazide-type diuretic or calcium channel blocker. If they are not Black, then we have more options: thiazide diuretic, ACE inhibitor, ARB, or a calcium channel blocker. These guidelines do not specifically address when to start combination therapy as initial therapy. If the patient's blood pressure is significantly elevated, 2 drugs might be necessary. So in summary, we want to initiate therapy when the blood pressure is above 140 over 90 for the majority of patients. That goal blood pressure for the majority of patients is going to be less than 140 over 90 now. And our initial treatment depends on race and comorbidities. But for most, we've got 4 drugs to choose from: thiazide diuretic, an ACE inhibitor, an ARB, or a calcium channel blocker. So that concludes our webinar today. I will now take any questions that you guys might have. Again, I highly encourage you to pull these guidelines and review them. There are some significant changes that we talked about today, and there's also a lot more details provided on the differences that we didn't have time to get to today.